from the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
I would like to welcome you to the 999th program of the North Idaho College Public Forum. The reason I have mentioned that number is we're about to celebrate, obviously, the 1,000th airing of this particular series of programs over 20 years, in fact, almost 21 years. And I'd like to take this opportunity to invite all those people who've been guests, panel members, our crew members on this program over those 20-some plus years to be with us on Friday, April the 16th at 7 p.m. at North Idaho College in the Boswell Hall Auditorium. We'd also like to invite our viewers who have been dedicated to watching our program, and we're going to go back over the history of all those programs and have some music and a wonderful time together. And we would like to invite you to be with us and to tell your friends who have been associated with the program to come. For our 999th program, we're going to discuss a very, very important and serious topic, and that is the issue of mental illness. And we have two very qualified guests today to discuss this very serious and important question. First of all, I would welcome to the program Dr. Victor Duarte, who holds a PhD in experimental psychology from the University of Minnesota, and his baccalaureate degree is in psychology from San Francisco State. I'm also proud to say that he is a tenured faculty member at North Idaho College. Welcome to the program, Dr. Duarte.
Thank you.
And I'm very pleased to also welcome to our program Elizabeth Mathis, who is also highly qualified to discuss this subject. She holds her baccalaureate degree in psychology from the University of Idaho and her master's from Arizona State University in counseling. She has, for 5 years, been involved in practice with a counseling agency in Spokane. Ms. Mathis, welcome to the program. Pleased to have you here. And as always, I'm very pleased to have our regular panelists. First of all is Janelle Burke, who is an attorney in the state of Idaho. And next to her is Steve Schenck, who is the Dean of College Relations and Development at North Idaho College. And I shall ask Janelle to commence the questioning.
In order to inform our viewers better what we are talking about, would you please tell us, Dr. Duarte, what are some of the kinds and types of mental illnesses?
Okay, well, I think the first thing to identify is how clinical people, psychiatrists, clinical psychologists, and counselors identify mental illness, and usually they guide themselves by a handbook of sorts. It's called the Diagnostic Statistical Manual. It's in its 3rd edition, and it's revised. And a 4th edition is due out soon this year, apparently. And this manual, in essence, lists all the various types of what are considered mental illnesses. And if I were to list some of the basic, some of the more common categories, I would say these would be the psychotic illnesses, the mood disorders, which would include depression and manic depression, also some of the anxiety disorders, which would include phobias, and then there also is a class of organic mental disorders, which include substance abuse, illnesses of that sort.
Can you identify for us some of what you would consider to be the more serious types of mental illness, as opposed to those which might be fairly frequent and much less harmful to the individual?
Well, it seems as though the psychotic disorders, the ones that really disturb the individual's relationship to others and also their relationship to reality, are probably the ones that are more disturbing for the person.
And what are those?
Typically, these would be along the lines of schizophrenia, those kinds of illnesses, and the subtypes of schizophrenia.
Okay, now, Elizabeth, can you tell us then how a person might, in a clinical setting, go about diagnosing an individual once they come in to see you?
Well, in the United States, again, the DSM-3, the book Victor Duarte talked about, is primarily the guide for diagnosis. And most diagnoses are really based on a behavioral description. Essentially, here's what you will be seeing in terms of behavior, motor behavior. Here's what you will see in terms of affect. Here's what you'll see in terms of cognitive processes. They also probably include just some course of the illness. When did it begin? How long has it lasted? And that's primarily the criterion. It's very specific in the DSM-3. Here specifically, they may give you basically 5 symptoms, and of those 5, you need 3 of them to make the diagnosis.
Let's take, for example, a schizophrenic, and maybe that's too broad, but let's take that. And can you kind of walk us through that process? The person would come in to you. I take it the person themselves, probably, not a family member, but the person themselves would come in, and they would tell you a story, and then from there, can you kind of
Well, basically, that's
happened?
probably when, if you're sitting across from the individual who's pretty acutely psychotic, it's probably one of the easier ones to diagnose. Essentially, you'd be looking at what is the pattern of thought processes. Usually you're looking at some sort of disturbance there. Their associations may be very loose or strange. Connected that with the 2, you may see delusions. Basically, are they having false ideas? They're saying they're Jesus Christ, or Martians are beaming thoughts into their brains. So you're looking at cognitive processes. Usually there's an affective disturbance also, where either the affect or the mood is inappropriate. They're telling you something rather sad and they're laughing, or it's flat. It's basically absent. Behaviorally, you may see disturbance in motor behavior. A lot of times there's a lot of agitation. One particular type of schizophrenia is recognized primarily by motor disturbance, and that's catatonic, where an individual basically is not moving in a catatonic stupor. Probably with the individual, depending on just how acute the episode is, you may also want to get information from family members, basically what has been the progress of the disorder. If a person is acutely psychotic, they may not be able to give you that information. You also want to check out their reality contact and ask them basic questions like, do you know where you are today? How did you get here? What day of the week is it? Who's the President of the United States? Basically to check out reality contact.
Steve Sheen.
Victor, a moment ago when you listed different types of mental illness, I didn't hear one of the few terms I'm familiar with, and that's neurotic. Is that just to psychotic as warm is to hot, or are they entirely different things?
Well, one of the things that has happened, I think, is there's been a developmental change over the course of the many years that we've had these manuals. That terminology was used in some of the earlier versions of the DSM, like the first or second version, and then that changed. So that now we've changed some of the terminology, but of course what it describes is still pretty much the same. It's just that rather we're delineating these categories more specifically, more concretely. So that in the old days we had that distinction with the psychotic being the more severely disturbed person and the neurotic less disturbed. And that's the reason why you don't hear that terminology much often today.
Is it possible for you to give us some idea of the incidence of mental illness in American society today? I mean, is it a disease that 10% of the people suffer from, or 15%? Or?
Of course, it kind of depends on the statistics that you're reading, but some of the statistics that I'm familiar with show that anywhere from 20 to 33% of the population will at any one point be suffering from mental illness that, if diagnosed, would in fact be diagnosed as mental illness. Of course, the majority of people may not necessarily seek help, but if they were to seek help, then that would be diagnosed as such. And of course, it depends on the subtype of illness. Mm-hmm. Schizophrenia is actually relatively rare, less than 2%, whereas substance abuse is up to 16%. Anxiety disorders are approximately 15%. So it depends on the type of mental illness.
Elizabeth, have those numbers, are they roughly reflected in your experience in clinical practice in this area?
Well, I think so. I would estimate, I think, say 30% of individuals at some time will show symptoms that could be diagnosed. I would say that's very conservative. I mean, we have a fairly simple diagnosis, for example, adjustment disorder, which just simply means that you've had a major stressor in the last 6 months and you're showing some anxiety and depression related to it, fairly common. And certainly substance abuse disorders are very common. So I certainly would agree with it and would probably consider it even fairly conservative.
In relation to all this, I did a series of programs some years ago in which we visited a mental institution and over a rather in-depth research interviewed the staff and even we got an opportunity to see some of the behavior of patients. So Victor, I will start with you and talk about, we read a lot in the media about a lot of crime and violent crime and that it's related to mental illness and all. In fact, that can even be a part of the plea in a case of insanity or temporary insanity and so forth. It's a very involved question, but would you for us distinguish between the types of mental illness as it relates to behavior? What I'm attempting to get at is that some individuals when mentally ill are very violent, others are very harmless and very passive, and particularly within just that category, if you would give our viewers some explanation, explaining both the illness and why that happens.
It seems like one of the problems that we've had in the last few years is this change in deinstitutionalizing individuals.
Yes.
And of course that's based on a combination of some of the advances in terms of drugs. Back in the late 50s, of course, we had many people in hospitals, but because of the use of psychoactive drugs, then a lot of these individuals were capable of going home and so on and so forth. And then of course political changes that have taken place in the last few years have led to more people out on the streets. And so what we have is a variety of individuals out there, some more severely disturbed, some less severely disturbed. And there really isn't enough of an outreach process to get at these individuals. So consequently, in those environments without that support, they're very likely going to get into circumstances in which they're going to be involved in some sort of criminal behavior. If they don't have access to therapy, then there are going to be more problems along those lines.
Isn't there a problem there too that sometimes when you go through the release of individuals, or as you're saying, there's a political trend in this country and philosophy to try to return people to the community on medication and so forth. Have we failed in any way, that is, for someone to be able to supervise closely to make sure the medication continues, and if it doesn't, what happens? And I guess what I'm also trying to ask is that in some large communities, such as New York, they have found that even though it was a very thoughtful and reform-minded process, that a lot of those individuals become homeless. They're not institutionalized and they're not in any home. What magnitude of a problem do we have there?
It seems to be great, although I don't know those specific statistics regarding that. Perhaps Liz might know more about that. But it seems like to me that that these individuals do need help. They seem to need that kind of contact with mental health agencies, let's say. And if they're not getting that from any facet of the environment, then of course they're going to be in more trouble.
My follow-up to Elizabeth is that I have 2 or 3 questions. One is that when we take 2 individuals and one of them is a criminal in behavior and very violent toward other people and maybe even physically violent, and another person is very much out of touch with reality but is certainly not dangerous to individuals, can those individuals have the same kind of mental illness at different degree or level, or is it a different kind of illness?
What you may be talking about with a more violent individual who has reality contact but basically lacks a sense of conscience is probably a different disorder. We're probably talking about a personality disorder, and probably most specifically antisocial, which is basically a separate category. Again, there we see disturbance primarily in just ability to feel guilt or remorse for actions. And I think there is kind of a myth about the other population, the more psychotic population, who do not have reality contact. I mean, they're very disturbing to be around. They disturb your sense of reality. They say there's pink elephants there, and you say no, there isn't. So it's uncomfortable. But I think we probably have more sense of dangerousness than they actually ever follow through with. They're probably less dangerous than they would appear.
In relation to treatment also, we've made a lot of progress in doing with that with medication. But give us the example of the types of mental illness that, even though you may make someone tranquil with medication and so forth, that it's impossible for them to ever return to a normal life.
Well, I think there's a population. If you look at schizophrenia, you're going to see different results in terms of treatment. Some individual will basically go through one psychotic episode in their life, get some treatment, and not have another one. There's another population who can maintain on medication, and as long as they're getting their medication, they can basically live in the community. But if they go off it, they will again need to be hospitalized. Then there's another segment who don't seem to respond real well to medication and probably will be institutionalized for most of their life.
Thank you. Janelle Berg.
Depression is a very common kind of thing, and so I would like to start with you, Victor, and would you just mention some ways in which you would identify depression? If there are people out there in our viewing audience who are feeling depressed, at what point should you seek some help?
Well, it seems as though, to a large extent, one of the things that I teach in my classes when I discuss depression is to think in terms of the individual. How much of their life is being implicated? How much disability is there? How much discomfort do they feel? Somebody else might say, you know, you're depressed, you're not sleeping as well as you normally do, you're changing your eating patterns. You don't interact with people as much as you have in the past. But unless the individual believes him or herself that there's in fact a problem, then they're not going to seek help. So one of the things that I like to talk about in my classes is the individual's own responsibility to determine for him or herself the severity of the problem. But sometimes, of course, others will have to intervene. And so under those circumstances, then family support is very important. And encouraging individuals who perhaps are changing some of these patterns to seek help is critical at that point. According to the statistics that I'm familiar with, anywhere from 5 to 12% of the population is sufficiently depressed at any one point in their lives to seek clinical intervention, but I'm sure that the majority of these people don't seek it.
Now, when you're treating someone who is coming to your clinic that has been identified as someone who's suffering from depression, what do you do? How successful are you?
I think depression can be fairly a disorder that can be helped quite a bit in a clinical setting. I think the first thing you begin to look at is just how depressed are they, and again, you know, look in terms of how well they can function. Are they depressed, but they can still basically make it to work and make it through the day? Or are they at a state where they're so depressed they can't get out of bed and it's threatening jobs? At that point, you may be looking at some medication. For myself, I always basically would make that an option, but again, an option for the individual, because individuals feel very differently about medication. Then just more of the talking therapies seem to be real successful with depression. Some of them focus more just on thought processes and thought patterns and changing those, and there's been some real success there. You can go into the more analytic type of treatment, looking basically at how they manage that depression in terms of defense mechanisms and basically looking at early childhood issues. And I think depression is actually a disorder that it is fairly readily treated in a clinical setting.
Now, I also have a question with regard to something that's been in the news a lot, and that's the pedophiliac, the person who has tendencies to sexually abuse children. Is that actually a mental illness, Victor, or how do you classify that?
Well, it is classified as mental illness under the DSM-3R, and I'm sure that category will stay there. So it is considered a mental illness.
And what are some of the kinds of ways that you would look at to identify that as, to identify a person as a pedophiliac?
Well, those categories I'm not that familiar with, so perhaps Liz might help.
Okay, and you also might talk, Liz, a little bit about treatment of those people, what is happening.
Yeah. Probably most of them are entering treatment on a court order. I mean, certainly some would enter treatment on their own, but I would think that would be the more rare side. And I think in terms of treatment, you're going to see a variety of treatment again. You can see real behavioral modifications in terms of just controlling their sexual and aggressive impulses. Again, you're going to see more analytic. And I think what you have to think about is this is really a spectrum. We may be dealing with individuals who are one-time offenders, who still have basically have some capacity for remorse and grief about what they've done, have some capacity basically to understand what happened to their victim. And certainly they are more amenable to treatment. And then at the other hand, I think we have individuals who basically, if you look at diagnosis, you will have the major clinical diagnosis, which would be pedophilia, and a secondary diagnosis could be something like antisocial behavior. Or again, they're lacking that capacity to feel grief or remorse, and they'll be much, much more difficult to treat. So again, it's a spectrum.
And is treatment successful?
I don't think I have statistics on it, but again, I think if you're dealing with the top half of that population, I would say yes. If you're dealing with the bottom half, I would say that treatment is not very effective.
Steve Schenk.
Victor, what's the current thinking on causes of mental illness? Is it, we talked about organically based behavioral problems like chemical abuse, but I'm thinking more along the lines of psychotic behavior or sociopaths that we've talked about before. Is this a physical, a neurochemical problem, or is it a combination of circumstances in a person's life that results in mental illness?
Of course, that goes back to the basic nature-nurture question, but the current thinking today is that there are generally two classes of etiological factors, the biological, genetic, or chemical, if you will, and then of course the psychological, environmental, learned types of variables. So if you classify them into those two broad categories, that seems to be the current thinking. And it kind of depends on the illness. It seems as though there's an active search for identifying genetic markers for illnesses like schizophrenia and some of the more severe forms of depression. And it does seem as though the basis of those types of illnesses have a heavy genetic loading, but others seem like they're pretty much, to a large extent, learned behaviors. I'm thinking of some of the phobias. So it kind of depends on the subtype or the type of mental illness in terms of whether it has a heavier genetic basis or a heavier learned basis.
Elizabeth, I'm going to guess, from what I've learned up to this point in time, that if it's behaviorally based, learned behavior, now you've got a chance to treat it through therapy. If it's a chemically based or genetically based thing, your chances of treatment, successful treatment, are less, or now we're definitely into using some sort of drugs as a treatment process?
I think that nature-nurture question is kind of a hypothetical one, because again, genes and the environment always interact, and I don't think you can make it so clear cut that one would be amenable to treatment this way and another one. Even if it's biologically based, you may find ways to cope through learning. So I don't think it can be quite so clear cut as that.
I want to ask a question that I hope that would be very constructive and helpful to our viewers. And we often talk about our physical health, and we can do certain things to maintain that, such as our diet, nutrition, and so exercise, and so forth. Would you be able, I'll start with you, Elizabeth, give our viewers some advice on how to maintain a mental health status and avoid at least some of these illnesses? I know if it's something that's organic, a tumor, for example, in the brain, is something that obviously sometimes is gone too far before things can be done, but just some advice on good mental health.
Yeah. Well, I think if you look at what would promote good mental health, there's a couple factors. One is maintaining a strong support system, whether that's a family support system or if that system is not very helpful, then building one, whether it be a community or family. That support system is very important. I think just in terms of keeping stress down, know your limits, know where they are, and be real adamant about keeping them. Certainly, as you look at categories of mental illness, major stressors, environmental stressors will, even if the illness seems to be biologically based, for example, let's say schizophrenia, which has some biological basis, under a great deal of stress, you're more likely to go in a psychotic episode. So again, to keep those stressors down. And I think just developing some basic coping mechanisms, for example, boosting self-esteem, thinking good things about yourself are always helpful too. And then recognizing when you need help. At what point do you need help, and allowing yourself to get it.
Your comments have sparked another thought from me too, and that is, doesn't society have a responsibility in everyone's mental health? I'm thinking of, for example, when you talk about self-esteem and so forth, if society is engaged in prejudice and bigotry, and particularly from the time someone is a very small child, they've experienced discrimination, that is certainly an attack upon their self-esteem. So can we not direct some of these comments at society?
Oh, I think so. I think if you look, any symptoms are personally meaningful and meaningful to society also. And you will see differences in terms of historically different disorders becoming more prominent and going away. And I think they reflect what's happening in society. And I certainly think society, is part of that solution.
Victor, would you like to comment on this?
I guess I would have to agree with that. Stress is probably one of the more important factors that may trigger or may predispose to a development of illness of sorts. And I think that it's not only a change that's taking place in this country, that is greater levels of stress because of the kinds of societies that we have. As you mentioned, lack of a social network, but also I think it's an international trend. Societies, as they develop, seem to predispose to more stressful circumstances.
Janelle Burke, we have about 2 minutes.
I wanted to talk a little bit about schizophrenia and also about split personality. And can you maybe identify for us, Victor, what some definitions are for those terms?
Of course, there is a classic misconception about schizophrenia in terms of split personality, but in reality it's not.
Would you identify that for us?
Multiple personalities, in fact, according to the DSM-3, are a different category completely. It's called a dissociative disorder. And really what it deals with is different parts of the personality disassociated from one another. So we have 1, 2, or 3, or 4 different personalities in the same person. But schizophrenia, as Elizabeth alluded to earlier, to a large extent deals with a loss of contact with reality. So the person who has multiple personality disorder is really not out of touch with reality. Each personality is in fact capable of interacting with the individual in realistic ways.
I'm sorry to interrupt, but we're out of time, and you have been most informative, and I know that the panel would join me in indicating that our viewers have acquired some very, very important information on a very, very important topic. Thank you for being with us, both of you today.
Thank you.
Ladies and gentlemen, I again know that you have found this most informative, and I would like to take time to once again remind those who joined our program in progress that this is the 999th program of the North Idaho College Public Forum, and I would like to invite you to be with us on Friday, April the 16th at 7 p.m. at North Idaho College at the Boswell Hall Auditorium, when we're going to honor all of you who've ever been on the program in any way or who've been our viewers. Come and celebrate with us the 1000th show, and let us talk about and look back at over 20 years now of this program that we've brought to you on numerous subjects with many, many distinguished guests and experts. Also join us again next week at the same time when we will discuss an important issue. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Telemedia Services on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station.